Good morning, good afternoon, good evening to the veterinarian from the different regions in the world. You are welcome to Sri Lanka Veterinary Association second International Webinar Series. We have organized 16 webinars at the second SLVA International Webinar Series. Our research persons are well-reputed veterinarians in Sri Lanka as well as in the overseas also. This is our 13th webinar. Today our topic is medical and surgical approach to blocked cat. Our resource person is Dr. Vipuli Kulasekara, small animal practitioner from California, United States of America. And our moderator is Dr. Diane Srivardhana from Pet Clinic, Colombo. So I would like to invite Dr. Susanta Mallavarati, the President of Sri Lanka Veterinary Association, to welcome you all. Dear President, over to you.
Thank you, Dr. Sugat, our immediate past secretary. Hope you can hear me.
Yes, we can hear you.
Yeah, good afternoon, everyone, especially our resource person, Dr. Vipuli. Welcome to this International Webinar Series session. And I'm really happy that she volunteered to conduct this session, though she is living in USA. And this time is not convenient sometime for her, but thank you, Doctor, for accepting our invitation. And also welcome all the members to this forum, especially from Sri Lanka Veterinary Association and also from other countries like India, Bangladesh, Pakistan, Nepal for this international webinar series. And we are glad that we could conduct many seminars, virtual sessions, and knowledge sharing. It was very well accepted by the members. And also it is a good, there were so many good feedback from our members regarding the outcome of this session. And thank you, Dr. Diane, for being a moderator for this session. And on behalf of Sri Lanka Veterinary Association, I welcome you all again for this seminar. And to continue the session, I'll hand over the session to Dr. Diane Srivardhana. Dr. Diane, over to you.
Thank you, Dr. Susanta. Today we are going to start the session with a topic that affects feline population, medical and surgical approach to the blocked cat by Dr. Vipuli Kulasekara, who is well known to many of us. However, I will formally introduce her to the audience today. Dr. Vipuli Kulasekara graduated from Faculty of Veterinary Medicine, University of Peradeniya in 1995. She started PetVet together with Dr. Nalinika Obesekara and Dr. Janaki Kollure in 1996. She completed 1-year clinical training in small animal medicine at School of Veterinary Medicine, North Carolina State University in year 2000. Completed her internship in emergency medicine and anesthesia at Tufts University, Massachusetts in 2002. Dr. Kulasekara has been working in the emergency residency since then. She has worked in Boston, Massachusetts, Maryland, and currently in Berkeley, California. She's also in the process of starting her own veterinary hospital. Her special interests are in respiratory distress, diabetic ketoacidosis, sepsis, bleeding disorders, complicated male cat urethral obstruction, and many more other disease conditions that are challenging in the emergency room. So we will start the session. Over to you, Dr. Vipuli.
Thank you, Dr. Diane. Hello, everyone, my colleagues from South Asia. I'm happy to be here and to share my experience and knowledge about this, condition in male cats. That is urethral obstruction, or we call it blocked cat. Can you guys hear me?
Yes.
Yes, doctor, yes.
Okay, so blocked cat refers to urinary obstruction in male cats. So it could be due to mechanical or functional obstruction, and these cats are unable to have a normal or no urinary stream. And if not treated, they can die from complications. So we see this like, all over the world because people have cats as pets. And so the reported incidents from emergency rooms are about 1.5% to 9%. And our affected cats are typically young to middle age. The mean age is about 4 years. And so the reason is like, why do we see urethral obstruction in male cats, but not so much actually never in female cats? It's because male penile urethra is quite narrow. And then that's why it makes, it is uniquely susceptible to obstruction. I have seen like 2 female cats in the emergency room being obstructed for bladder stones. I think that's all compared to the 1,000 urethral obstruction in male cats that I have treated in the past 20 years. Okay, so that's my card. Okay, so let's talk about causes or predisposing factors, clinical signs, pathophysiology, diagnosis, treatment, and long-term management. So predisposing factors. So as I mentioned before, commonly seen in young male cats, but we do see some older cats getting obstructed, mainly due to bladder stones. And the other factor is cats fed on a dry-only diet, mainly free feeding. The reason is dry food has only 5% moisture. So I sometimes talk to clients about cats being on dry food, like compared to, just like imagine people eating just like dry, dehydrated food, like for example, dried potatoes or potato chips and dried fruit. And if you try to eat just the dry food, like, you are going to get dehydrated, chronically dehydrated. And then cats, when they eat dry food as free feeding, they overeat. So most of these UO cats or urethral obstruction cats are overweight. And then when they overeat, they are consuming high amount of minerals or salts. So that's like one of the reasons. And the other one is early neuter. So early neuter leads to smaller urethra because they don't have testosterone for growth. And the other factor is extremely nervous or anxious male cats, especially if they are on multiple cat household or they live with small children or with other dogs. So this is rare in female cats. So that's your typical cat that I see in the emergency room, really overweight. So what causes UO? What is the pathophysiology? So crystalluria, this is like, crystalluria, there are 2 kinds. One is true white and the other one is oxalate. So true white is the most common one that we see in the emergency room. So this is true white crystals. It's easy to diagnose. Diagnose under a microscope. They have like diamond shape. And then this one, it's true white crystals too. And sometimes this is like, what we collected from a bladder of a cat. That's it's all sand, true white crystals. And this is oxalate crystals. That's not that common. And the next one is mucosal plugs. So urethral plugs are solid, soft masses composed of crystals, mucus, protein, and cellular debris. So they are thought to be as a result of chronic bladder inflammation. So this one, sometimes I do see this color mucosal plugs. Sometimes it's like just white because it consists of mainly true white crystals. and these are stones. So stones are common in older cats. So I have seen few in the emergency room compared to the steroid crystals. So the other cause is bladder and urethral spasms. So severe inflammation causes bladder and urethral spasm, causing functional urethral obstruction. And it's common at onset of clinical signs of poor urinary catheter phase. So we give pain medications and muscle relaxants for this condition. Urethral strictures. This is seen after urinary catheterization and rarely congenital. And I think I saw 2 cats in the emergency room, and I tried to avoid a PU surgery, but then realized both of these cats had very narrow stricture. It was congenital, and these both cats were 8 months old. Then let's talk about signs of urinary blockage. So cats that are partially or fully blocked often show some of or all of the signs. I think I'm sure most of you have seen this in the exam room. And so straining to urinate, and then they produce only small drops of urine, and sometimes it consists of blood or clear urine, and crying or howling in and around the litter box. And they also have this furious licking of the genitals, and that itself causes severe inflammation, because as you know, the cat tongue it's rough. So if they keep licking the urethra, there's severe inflammation. So in my opinion, I think that is one of the main causes for obstruction, because inflammation, they're not able to urinate. And these crystals get together along with the mucosa, the bladder lining that has sloughed off and forming the plug. So this can be seen even after we treat for urethral obstruction. These cats go home, and then a few days later, they come back to the emergency room because they're blocked again. So what I try to do is I try to send all these cats with an e-collar, at least to be worn for 5 days until the inflammation it's subsided. And then sometimes we would see vomiting and not eating. And most of these cats really resent being touched or being picked up. So clinical presentation. So when clients call us, they always say my cat is constipated, because what they see is cat going to the litter box and straining. And so on presentation, it depends on the situation, if it is partially obstruct or completely obstruct. So some of these cats are alert, bright and alert, but you do see straining, and then others are at dead still. So this is classical posture for straining to urinate. So when clients call us, we actually ask them to take a photograph so that we can evaluate the patient. And then if it is lower urinary tract disease, then it's an emergency. And if it is actual constipation, they can wait for an appointment. And the other is you can see normal positioning when they urinate, and then positioning for straining. That's really classic. So when we see them in the emergency room, we always triage, we triage every patient who comes to the emergency room. So what it means is when the client comes into the waiting area, the technician goes to the front and get the vitals, temperature, pulse, respiratory rate, and mucous membranes, and get a brief history. And if it is not an emergency, then they have to wait, and then we take the most critical patient. So technician will triage these patients. The reason is, so there are various clinical signs, sometimes classic lower urinary tract signs, and the other signs are very vague. ADR, that's like, what we use. It's what people use. It said ain't doing right. So we use it as a clinical sign, ADR. And so the technician has to do, like every male cat, my technicians are trained to check the bladder. So if the bladder is big, then they will alert us. And then the veterinarian goes and rule out whether the patient is blocked or not. So the hallmark physical examination for urethral obstruction is large, it could be moderate or small, but very firm bladder. On palpation, these patients show severe pain. So this is you can see this is a big bladder. And then the kidneys are actually enlarged too. I'm sure this cat had severe azotemia. So blocked cats. So these blocked cats I'm talking about, they're the very severe cats who are at death's door. So they can be bradycardic or tachycardic. So bradycardia tells us that the cat's potassium is really high. Tachycardia, they could be hyperkalemic or high potassium, but they're not as critical as the cats who are bradycardic. And then they also have hypothermia and obtunded, and they need immediate stabilization. So let's talk about stabilization for these critical urethral obstruction, or UO cat. That's how we refer them. So when I see a very critical UO cat, the first thing I do is getting an emergency consent from the client, because in the US, we cannot treat our patients without the consent of the owner. So this is done by the technician. So we have various ways, different hospital uses different methods. So the current hospital that I work, we just verbally tells the owner, get a verbal approval, and then they have to leave a deposit so that they know what they're getting into. And then next step is like place an intravenous catheter. So all these things happen at the same time, like within, I would say 10 minutes or 5 minutes period. And then we get the blood from the IV catheter itself, not a lot, just a few drops to get electrolytes and BU and creatinine. So that way we know how critical this patient is. So while the blood test is running, we give a small fluid bolus, 5 ml per, I like to give 5 ml per kilogram. And then once upon a time, I think it's like 15, maybe 18 years ago when I used to practice in the East Coast, we were told not to give fluid until we unblock the cat. But that thought process has changed, because a critical urethral obstruction cat has these metabolic changes, for example, elevated potassium or hyperkalemia and metabolic acidosis. So we will improve their status by giving a shock bolus of fluid. And my colleagues sometimes give 10 ml per kilogram. So we'll give like a fluid bolus. And then the next is, if the bladder is really big, it's like, that will affect the pressure towards the urethra. So again, this was a thought process where a long time ago, we were afraid to do decompressive cystocentesis because we thought it could lead to uroabdomen or rupture of the bladder. But there are benefits of doing decompressive cystocentesis. So we can reduce the bladder pressure. That will actually affect the kidneys, right? Then there's no back pressure to the kidneys. So we can improve the GFR. And also we can collect an uncontaminated urine sample for analysis. And we are also going to reduce the pressure to the urethra. So that will be, that is then it's easy to pass the urinary catheter. Okay, so this is the treatment that we use for hyperkalemia. So intravenous fluids, and then calcium gluconate. I like to give regular insulin and glucose first, because the rationale is the potassium will be pushed into the cells. And some of my colleagues like to give calcium gluconate because it is cardioprotective. So sometimes I do that both at the same time. So two technicians will be drawing these drugs, and then we have the catheter with different ports. So we can give these medications at the same time. And sodium bicarbonate will improve the metabolic acidosis. So terbutaline, I don't give terbutaline, but some of the practices do that because we don't carry terbutaline in every hospital. Some hospitals do use that. Okay, so next step is, once we stabilize the patient, then we have to sedate the patient for de-obstruction. So the choice of drugs depends on how sick they are. If they are really unstable, you can actually pass the urinary catheter without giving any medications. That's like a really quick. The patient comes in like almost like, at the death step, and we can pass the catheter. Otherwise, most of the time I give methadone, the pain medication, to unblock. So my go-to diazepam and methadone, and then we have alfaxalone. It's actually really safe for cardiac patients, and that's for unstable patients. Stable patients, I use methadone, diazepam, and dexdomitor. Okay, and then next, urethral catheter placement. So this is like really important. That aseptic techniques are very important to not to introduce bacteria to the bladder. So I'm not going to, I thought like I'll skip this. So we clip the perineal region and then extrude the penis. And that's actually important. I'm going to show you a video of this. Actually, this morning, my colleague was unblocking a cat when I went to work at 7 a.m. So you extrude the penis and you have to retract caudally. And you basically like this, and then you have to kind of turn vertically, and then you pass the catheter like this, not like this, because you are going to hit the sigmoid flexure, and then there'll be like, it will be hard to pass the catheter. And so the other thing is like, everything has to be done gently. So the bladder is very inflamed. So when you are pressing the bladder, it has to be done gently. And the urethra needs to be handled gently, and passing the urinary catheter gentle. Everything gentle, gentle, gentle. Okay, because sometimes we forget because you're stressed and you want to do this as quickly as possible. So sometimes we forget that we are actually dealing with very sensitive organs. Okay, next one. Oops. Okay, and then once so while you're passing the catheter, I'm sure you guys all use this, like, use the urethral irrigation. It's called hydropulsion. We use sterile physiologic saline with an extension tube, and then you basically pulse it to kind of push the obstruction. And then I don't actually, once I hit the obstruction, I actually pull back the catheter just few millimeters. So that way I can have that saline ejection, the water stream hitting the obstruction. So slowly then you retropulse it to the bladder. And if it is hard to unblock, I use sterile loop 50-50, and that will actually facilitates the de-obstruction. Okay, so let's see.
Yeah, that's what I was looking for.
So this is actually this morning. My colleague, she just graduated from vet school last year.
Again? We got past that first.
Sorry. No, go back. What's going on? Sorry.
Keep going back. Number one.
Bear with me. So how? Okay. Yeah. Okay. Apologize. Like, I think my colleague is talking. So she's trying to. This is a 10-year-old cat named JC who came to us this morning, and he had a really big bladder. And so my colleague had a hard time passing the catheter, and she felt nervous. She did not want to do the decompressive cystocentesis. So we tried to pass the Tomcat catheter, and it was hard. And then I actually jumped in, and I used the 24 gauge IV catheter, which is really short and really narrow, and try to de-obstruct. So I was able to get like a small urinary stream and then empty the bladder halfway through. And then we tried the Tomcat catheter again. And so it was still hard. So then we used the red rubber catheter and was able to get into the bladder. The urine was really bloody. And so this is the hydropulsion. Okay. So, after that, so this is a slippery sand that we use in our hospital. So they come in two sizes, 11 centimeters and 14 centimeters. And the diameter is 3.5 French. So she's actually suturing into because there are two holes where you can attach the catheter to the skin. It has less irritation to the urethra. I like these catheters. And you can see how bloody the urine is. Okay, so we have our monitor to check the EKG and the SpO2. And my technician is giving oxygen. And this is how the positioning of the de-obstruction. The patient is on dorsal recumbency. The hind limbs are actually pulled forward, so we can easily retract the penis. And then she's attaching the catheter to close the collecting system. So after we pass the catheter, then we flush the bladder until the urine clears up, until there's no more debris, no more blood. And sometimes if the bladder is really inflamed, there's so much bleeding, these patients can become anemic. So I started using cold sterile saline at the start of the treatment, so that way we can help vasoconstriction and reduce further bleeding. And I actually tried that with our patient JC this morning. And initially he had frank blood. I think there was about like 20 ml, 30 mL of frank bleeding. So we tried this saline treatment, 20 mL every 2 hours. I had to do only twice, and then urine actually became clearer. And at the end of my shift, urine was just like light pink. So that was really good. And then this is my technician is attaching the clothes collection system.
Compared to a Milo? Actually, I think I don't like the Milo anymore.
So you can if you don't have these bags, sterile bags, you can use empty saline bags to make a clothes collection system. Okay, next one. Okay, so now then JC is back in the kit. We have started him on IV fluids, and he is like coming out of sedation, or that is like the dysphoria due to methadone. He's in a happy world. And you can see he is overweight. So that bloody urine is before flushing the bladder with cold saline. Okay, so this is like, this is what we want to achieve. So on the left, you see like really bloody urine. And then so the flushing has to be done really gently. And then your goal is to achieve that clean, clear, saline like urine. But sometimes you can't achieve that if the bladder is really inflamed. Okay, so let's talk about types of urinary catheters. I don't know in Sri Lanka or in South Asia what type of urinary catheters you use. So here we have Tomcat. So Tomcat is used only to unblock the cat, because it's really rigid and it causes severe damage to the urethra, because it's like really rigid. So red rubber is like your go-to, because it's not expensive, and a long time ago that's what all of us use. So some of my colleagues still like red rubber. So cat, I have not used cat in my practice. I use Slippery Sam and Myla. So Slippery Sam is the advantage of Slippery Sam is it's 11 centimeters and 14 centimeters. So you can actually, you don't have to measure the size, like the distance that needs to be inserted to the bladder. Small cats, 11 centimeters, large cats, 14. Whereas red rubber, you have to measure, because you can't have the catheter too far in or, too out in, so out. So, but red rubber is good. It is actually easy to use. And Surgivet, like some of my colleagues in other hospitals use Surgivet, and it is expensive. So we don't have it in my hospital. Okay, so post de-obstruction care. So the de-obstruction or unobstruction, usually occurs within like 10 minutes or maximum 20 minutes. And the most important part is the aftercare, because these patients are going to stay with you for 36 hours to 72 hours. So what are the post de-obstruction care? So maintaining urinary catheter. So what do you mean by maintaining urinary catheter? So urinary catheter, when the patient has the catheter for 36 hours, there's a lot of things can happen. One of the most common example is the catheter getting blocked with blood clots. So these blood clots can be at the beginning of the urethra or at the end of the collecting system. So one time I had a cat, he was not producing urine. So my technician came and alerted me, the cat is not producing urine, there must be a blockage somewhere, or he's in severe kidney failure. So I already had the blood test. So his azotemia was improving. So we kind of ruled that out. And then I asked the technician to flush the catheter. So it was, flushing really well. And we couldn't figure out where the blockage was. So together we looked at the entire line, including the collecting system. And then we found a blood clot at the junction of the tube and the collecting bag. There was a blood clot hiding that we did not see. So since then, my protocol is if the line is really bloody, there are blood clots, you change the line so that way we can get rid of these errors. So that's one. And the other one is if the cat is really too active or dysphoric, they can kind of entangle the catheter, urinary catheter line with the intravenous line. So that's the other one that we have to keep an eye out. So what we do is we every 2 hours a technician will go and check the patient at least for first 6 hours, and then we extend it to every 4 hours, and then next day every 6 hours. The next one is provide adequate fluid therapy, because these patients are really dehydrated, acidotic, and also azotemic. So each patient, we have to calculate their requirement. So depending on the status of their metabolic status. And the other important condition that we see is post-obstructive diuresis. This happens to almost all of the UO cats that are azotemic and hyperkalemic. And then we monitor for secondary UTI. That is when once that we pull the urinary catheter and when they go home, they are prone to UTI because just by placing a urinary catheter. And then electrolyte support, we do blood test every 4 hours initially, first 12 hours, and then 6 hours to 12 hours. So depending on the patient again. And of course, analgesia. So again, pain control or analgesia depends on the severity of the obstruction. So today, my patient JC was started on fentanyl CRI. So fentanyl is it's not that expensive here in the US compared to methadone and hydromorphone. So we use a lot of fentanyl for severe pain. So I use 3 micrograms per kilogram per hour, and then evaluate the pain by monitoring the patient's attitude and how he's moving around, and then also gently palpating the abdomen. And then sometimes I increase it to 5 micrograms per kilogram per hour. So JC was able to stay on 3 the whole day until the end of my shift. And then sometimes we use methadone 0.3 mg per kg every 6 hours. And if they're not that painful, those are uncomplicated patients, buprenorphine or buprenorphine, 0.02 mg per kg. So I don't know what kind of pain medications Sri Lankan veterinarians have these days. But I think if there are so many lower or fluted cats that we call, or UO cats in Sri Lanka, you guys have to think about getting these opioids, at least buprenorphine. That is a good pain control for UO cats. And urethral care is basically after the catheter, there's like so much swelling and inflammation. Sometimes some doctors, including me, I gave like 1 dose of dexamethasone sodium phosphate. So let's talk about, like, I'm just going to briefly touch post-obstructive diuresis. And this is like one of my favorite conditions because it's you need to like be alert and kind of manage it like hourly basis. So nobody knows like why this happens, but there are these theories. Because of severe obstruction, there's basically damage to the kidneys, nephrons may be destroyed. As a result, there's diuresis that happens. So the way we know is, so normal urinary production for a cat or a dog is about 2 ml per kilogram per hour. So we do measure this urine every 2 hours and then calculate and see whether it's less than 2 ml per kilogram per hour or more than 2 ml per kilogram per hour. Sometimes I do see some cats passing urine like 6 ml per kilogram per hour. So if it is a 10 kilogram cat, 10 pound, like 5 kilogram cat, it's going to be about 30 mLs per hour. So that's a lot of urine. And then we have to match the amount of urine they're passing with IV fluids. So we call it ins and outs. So when we talk to the technicians, we ask them like, tell me the ins and outs, does it match? If it doesn't match, then they need to let the doctor know. So usually this post-obstructive diuresis lasts for about 6 hours. Sometimes it can go up to 24 hours. And then at some point we have to think about, am I driving this diuresis by trying to match the urinary output? The intravenous fluids maybe is driving the diuresis. So then we need to back off. We need to kind of slowly try to reduce the amount of IV fluids that you're giving and see what happens to the urinary output. If the urinary output reduces, then we know we don't have diuresis anymore. If it is still high, then we need to keep giving the IV fluids. Okay, so post-obstruction care. So what happens after we de-obstruct the patient? So usually I send them home with pain medication for 7 days, 5 to 7 days. We combine an opioid with gabapentin. And I never give NSAIDs because these patients just had very compromised kidneys. Even if the B1 creatinine, kidney values are normal, I hesitate to give NSAIDs. Now what I do is I give like 1 dose of anti-inflammatory dexamethasone. That is when they are in the hospital. Never give antimicrobials because this is not an infection. There's no, we also do, one of the hospitals do urine culture at presentation, and we rarely see any bacterial infection. So if you are concerned about a UTI, it usually happens after we remove the urinary catheter, usually 7 to 10 days later. So that's when you actually have to do the urine culture, and then if it is positive for bacteria, start them on antibiotics. Okay. Okay, so we also start them on urethral relaxants. So there's prazosin and phenoxybenzamide. So most of us like prazosin because it actually has a better outcome in terms of reobstruction. But one thing we need to know is that prazosin affects only the proximal 1/3 of the urethra because it's a smooth muscle relaxant. So male cat urethra actually has skeletal muscles at the distal end. So by giving diazepam, you can actually relaxes the entire urethra. So let's say you combine prazosin with few doses of diazepam, then you can actually have complete relaxation. So that's the reason we add diazepam for our sedation, so that it's easy for you to pass the urinary catheter. Okay, so next is discharge instructions and then home environment modification. So we actually talk to the owners in detail or at depth, the causes of urethral obstruction. So it's like a multimodal. There are so many factors. So we think it's mainly indoor cats who has a lower urinary tract or fluted or FLUTD, and I have yet to see like an outdoor cat getting obstructed. So if these indoor cats are getting obstructed, then we need to figure out like why. So like they think like, it's because they are really bored and stressed and have a relationship with food because they are bored. So we need to make the environment really interesting. So increase contact time between cat and owner, because most of the owners, they go to work, one cat at home, or a stressed cat with another fierce cat. So because of all these factors, we tell them you need to play. There's play time with the owner. And then the other important thing is litter box hygiene. So we always say number of cats plus one is the number of litter boxes you need to have. So I have 3 cats and I have 5 litter boxes. So because all of them are male cats. So I'm petrified that I am that owner that's going to miss an obstruction. And then cleaning the litter box every day. That's really important. So one of my veterinarians, and in internal medicine doctor, one time gave a talk about urethral obstruction and asked the audience, what do you think, if there's an unflushed toilet, would you go to that toilet? So think about that, if you forget to clean your cat's litter box, it's like, you're going to the toilet that has a lot of unflushed, so many people have gone to that toilet. So that's actually really important because cats are very clean creatures. And then dietary modification. So this is what I actually tell owners. So in my opinion, I think dry food is the culprit. It's a very artificial diet, 5% moisture, and it's dry. So you can easily overfeed your cat. It's just like us, we can eat a bag of potato chips without any hesitation. But if I give you boiled potatoes, you can't eat the same amount of dry potato chips that you're eating. So it's the same concept. So I actually don't even recommend a prescription diet. I explain to the owners, it's like water is the most important thing. It's the saying, it's a solution to pollution is dilution, right? So what I tell owners is I want the urine specific gravity to be under 1020 or 1020, because most of the cats come in, their USG is 1050 or 1060. So when they go home, I actually want them to come back 7 days later to see what the USG is doing, whether the owners have been compliant by feeding wet food and providing more water. So if we can achieve that 10-20, then we won't see this problem because there's no precipitation of salt. And then environmental enrichment, all these cat perches and hiding places, which I have for my 3 cats. Since I work long hours, and I'm worried, I'm going to miss that obstruction. So, okay. So that's it. I think, did I go too fast? And any questions? I think I'm done with the talk, and thank you very much, SLVA, for giving me the opportunity to give you this seminar. And you can, this is the question time.
Thank you, Dr. Vipuli, for that interesting and informative speech. I think there are a lot of new information that we gathered from her talk. If you have any queries, you can actually directly ask questions, or you can type in the chat box. She's ready to answer any of the queries you have.
Dr. Vipuli?
Yes.
This is Lanka. Doctor, for how many days you give diazepam usually? Like for how many days you prescribe when you discharge the cat home? Because some people are about giving oral diazepam long term to cats.
No, I don't give oral diazepam because of the liver damage that they have. I give diazepam when they are in the hospital. So I give a dose of diazepam before I pull the urinary catheter. So that way, kind of
morning and evening kind of a thing.
Yeah. So it's at the beginning when I'm just before I unblock the cat, I give a dose of diazepam, and then just before I pull the urinary catheter, I give diazepam. But we have midazolam. We actually have midazolam that does not have this effect, like the liver damage. So if I want, I can give it every day. It all depends on how. I also look at the urethra, and if I see a lot of spasms, I give as needed basis.
Right. Thank you.
So I don't know whether I would recommend sending them home with diazepam.
Right.
Dr. Vipuli, like for the inner sphincter relaxation also, do you give anything? Now, the midazolam usually works for the outer sphincter, right?
No, yeah, prazosin, exactly, outer sphincter. So inner sphincter, I think if you give pain medication, so the bladder spasms and inner sphincter spasms happen as a result of severe pain.
Mm-hmm.
So if you give some kind of pain medication, even gabapentin,
gabapentin, yeah.
Yeah. So do you have opioids in Sri Lanka?
No, we don't. We can't readily buy it. Like sometimes we can, but not readily available to purchase.
So when I was in Sri Lanka, we had pentazocine. I remember using it a lot.
That's also not available anymore.
It's not? Okay. Because that's actually a really amazing drug, like for this these cats. But if you have gabapentin, then you can actually give high doses. And then the other important thing is the e-collar. E-collar is like really important for 5 days. Because they, like, I think my friend's cat, got obstructed. I'm sure it is because no e-collar licking the urethra, till it falls apart. So that's why they get reblocked. So, and I also tell the owners not to throw the e-collar away. Whenever they see this licking the urethra, put the e-collar. And then I also send acepromazine. That's a good drug for smooth muscle relaxation. But some of the clients that they don't like to see the effects of acepromazine because it has like sedative effect. So when I was in the East Coast, Maryland and Boston, that's we gave acepromazine and Bipronex. So acepromazine is actually better than Practitioner, because it's not the sphincter that is actually the problem. It's the entire urethral muscle. I don't know, like, whether any of you have had a urinary catheter, like, maybe C-section, but I know I had one. And it's like, I was thinking about all my patients, because you can't go to the bathroom, you can't pee, because there's so much like inflammation or urethritis, there's so much spasms. So that's what happens to cat's eye. So my goal is, I said surgical approach, but my goal is to avoid the PU surgery. I am against PU surgery. So I talk to owners for a long time to make them compliant. Like and then I tell them, this is how I talk to them. I said, okay, if you're not compliant, we make your cat a girl cat. We're going to cut off the penis and make it a girl cat. And that has a very big effect on most of my clients. They become very compliant. But we do PU surgery in California because of the cost of unblocking, because it's like really expensive, $4,000, and 3 times, then you're spending $12,000. So a lot of people or veterinarians recommend PU surgery because of that. But what owners don't understand or realize is, like, we are not solving the problem of FLUTD. They are still going to have bladder inflammation and crystalluria. It's just like, we are making a bigger opening so that they're not going to get obstructed. So being an emergency doctor, I have seen the other side of PU surgery, because down the line, many years later, these patients come with like severe bladder infections. I had like one that had a severe pseudomonas infection that had, like, I could smell pseudomonas, like just by, like, being near the cat. And it was very difficult for us to treat him, because he was resistant to, like, pseudomonas was resistant to most of the antibiotics. So I try to, like, PU surgery, we do PU surgery a lot here, but my goal is to kind of tell the owners this is a man-made disease. So it's like just like the gastric stapling that we do, like, for humans, right? So weight loss and shying away from dry food. And another thing I do is, like, kittens. When kittens come, I don't like do kitten care, but if I see a kitten for URI, I give my spiel about, if it's a male cat, I give my whole spiel about dry food, bad, and just feed them wet food, and about, like, this lower urinary tract disease.
So when we have pets like cats, like, do you recommend, like, say, male cats or even female cats, from the beginning, do you recommend wet food and dry food combination, or, like, is the dry food bad for the cats? Or are you starting food, like, wet food when you see signs of FLUTD only?
No, so I recommend, so this is what happens, Dr. Dayani. So because owners are lazy, right? They don't, so if a cat is eating dry food, the amount they need to eat is 1/4 cup of dry food per day. It's such a small amount. And the cats are going to be hungry. It's just like the example is, I give you 2 boiled potatoes, you'll be full, but I'll give you a bag of potato chips, you still can eat more, like more potato chips, because you're not full. It's the, it's the gastric distension, right? Like, that's the feeling of full. So for the cats to feel full, they have to eat like 3 times their requirement. So if I'm recommending, like, sometimes owners say, no, my cat loves dry food. So then I tell them, okay, so going back, 1/4 cup of dry food, and if it's wet food, it's only 5-ounce can per day. So then I tell the owners, you give just 1 tablespoon of dry food, and then as a treat, and then divide the 5-ounce twice a day. And it's hard, like, my cats are hungry all the time because I limit their food, and I do give dry food because Otherwise they go crazy. But it's just like, just a handful. And then when I give wet food, I add a little bit of water before I offer them the food. So you can actually tell, like, especially all of you can talk to owners about this issue before it happens. When they come to you for their first kitten vaccine. Like, think about it, like, if a cat is like outside, how often do they eat? They catch a bird like once every 3 days, or a rodent. So that, because they are carnivorous animals, they are obligate carnivorous animals, and we give them carbohydrate, right? The dry kibble has carbohydrates. They don't need that.
Okay. Because it's interesting because we see quite a lot of block cat now these days. And also they end up in PU surgeries, some of them, because a lot of people are so frustrated of going through the episodes of, blocking and, unblocking situation, same as yours. So the owner is more frustrated than the cat. And so the owners try to avoid going through the episodes of the unblocking, and they request the PU surgery. Or they end up in kidney failure. That's the other problem.
So why kidney failure it is reversible kidney failure. If like 99.9% of my cats, when I unblock them, they become azotemia improves sometimes within 24 hours, and definitely at 48 hours, kidney values are normal. So if your patients actually have permanent kidney damage, maybe they need more fluid requirement during the hospital stay. Do you see, like, patients with azotemia?
Azotemia, like, repeatedly, because as they block every time, like, frequent blocking happens, like urethral obstruction happens quite frequently. That's what makes.
For example, like 3 times, like, within
3 or 4 or 5 times. Sometimes they are reluctant to, do the behavioral enrichment, and, their owner compliance is another issue in some cases. So then they get frequent blockages.
Yeah, so I think maybe because when I was practicing in Sri Lanka, we didn't have dry food. We didn't have this problem. Only time I think I saw few patients from expats, like the Italian ambassador's cat. We didn't have urethral catheters, I remember. And then some other ambassadors, like, cat, because both were on dry food. That was my first experience. And the fact that you see more now, I think it is diet related. And also it could be also Sri Lanka has changed. Maybe people live in more apartments versus houses, or is it like, has it changed?
Not much, like, mostly they are semi-roaming cats and like in household cats.
Oh, really? So they're not indoor only cats?
No, because multiple cats are in one house. Most of the animals who are getting these urethral obstructions are with multiple cats. I mean, get some like one cat, single cats, but mostly we see multi-cat household environment. Okay,
so I think you need to, all of you should actually look at this issue as a nutritional, like, dietary related. Because I'm sure, like, all those cats eat more than they need. If they are on a dry only diet, maybe they have to reduce the quantity or add wet food. Definitely reduce, like, you have to show them like 1/4 cup, and it's pretty small. It's really small, and I don't think my cats will be happy feeding 1/4 cup of dry food for the whole day. So that's what, 5 ounce or 1/4 cup. And also it's the water. So you can actually do a study, like all of these cats that you see, what is their USG? If the specific gravity is more than like 1030 or 101, 0.030, 1030, they are going to precipitate and then cause this problem.
Okay. So are there any more questions that she's happy to answer?
Yeah, I'm fully awake. So
Dr. Vipuli, this is Sumasha. Thank you for very interesting lecture. Can we use tramadol as a painkiller, because we can't give meloxicam in SAID? So we have sometimes tramadol. Is that useful?
So tramadol, we used to use tramadol a lot, but studies have shown that tramadol doesn't have any pain control. So I don't use tramadol, but definitely if you don't have, Buprenex, definitely you can use tramadol. And then, so do you guys use steroids as like an anti-inflammatory, like just one dose? Dr. Masha?
Yes, doctor, we are not doing at the moment, but now we can do actually, because after your lecture, so we know now we can. Thank you.
Yeah. So because the thought process was, you can, reduce immunity by giving the steroids, but there are two different doses, right, for steroids. One is the anti-inflammatory dose. It's very small, 0.07 or 0.02 mg per kg. And the immunosuppressive dose is 1 mg per kg. So as long as you give the anti-inflammatory dose, you don't have to worry about reducing the immunity.
But that again, single dose, right?
So I give single dose, yes, but you can give for 3 days with no issues. And other thing is, other rationale is cats can handle steroids. They don't have the GI signs that dogs get. So let's say I was practicing in Sri Lanka and I had limited, medicines that I could use. I would definitely use 3-day course of steroids versus doing a PU surgery or having recurrent urethral issues.
Dr. Vipuli, are you giving Hytrin also, or just only gabapentin and painkiller after the catheterization?
I didn't hear the question, Dr. Masha.
Are you giving Hytrin also actually after removing the catheter, after 3 days, are you giving Hytrin plus the gabapentin, or just only the gabapentin and the painkiller?
Did you say the muscle relaxant, the prazosin?
Yeah, it's similar to trazocine, yeah.
Oh yeah, no, I give prazosin. So prazosin, gabapentin, Buprenex, or buprenorphine. They have three medications. Yes, I do the muscle relaxant.
For how long, doctor?
So 3 to 5 days. So it depends on how much. Yeah, so you can give for 5 days.
That means after removing the catheter for 5 days, right?
Yes. But I start the muscle relaxant before removing the catheter. We start the muscle prazosin in the hospital.
Okay, thank you, doctor.
And what opioids, do you have any opioids in Sri Lanka? Butorphanol?
We have limited stocks again. On our user permit only we can get it. It's not readily available in the country.
Okay. Any other questions?
Any other questions?
I can answer anything. I don't know. I actually covered a lot of what I thought it will be too much if I talked about, for cases who doesn't, people who don't have money, how we treat. I did not cover that because I thought it will be too much. I don't know whether you guys practice this, if somebody comes with no money, what we do is we basically cystocentesis, decompressive, and then give pain medications, e-collar, and they actually get better. That's one way. And the other one is, we call it treat and street. That means I pass the urinary catheter, flush the bladder, load them with pain medications, and they go home. And then I actually follow through that, I basically keep a tab on them to see whether they get blocked. So surprisingly enough, they actually, because these owners are compliant because they don't have money, so these cats don't come back to me with a repeated offense. So I do that a lot in the practice. So you can actually, that's something that you can do, if people can't afford.
Good
So
to know
I have a
that.
question for you guys. How many of you do this, the UO unblocking in Sri Lanka?
I think in Colombo, many practices have started. I'm not sure about out of Colombo areas though. Even in the university, if anybody has joined from the university in this discussion, they can answer. Anyone is here from the university? Doesn't look like.
Okay.
Okay, then. Thank you very much, Dr. Vipuli. This is relatively a new topic that we discussed here. I think most people are not aware of this feline disease in many parts of the country. But this is I think, a beginning of starting of same discussion. But we probably can have another discussion about this fairly extensive discussion in how to do the surgical management as well in the future. So with that,
you can do that. You're the expert for PU surgery, right? I think that's actually important.
So, thank you, Dr. Vipuli. Dr. Chamari, I would like you to invite you to give the vote of thanks.
Thank you. Thank you very much, Dr. Dayani. Hope you all can hear me.
Yes. Yes, we can hear you.
Okay, thank you. Thank you, Dr. Dayani. On behalf of Sri Lanka Veterinary Association, I would like to thank Dr. Vipuli for accepting our invitation to do the presentation today. Thank you, Dr. Vipuli. Even though the time in USA it's midnight, you accepted our invitation, and thank you very much for your very informative and very interesting presentation. I hope all the audience today, those who have joined today, must have gained a very good understanding about block cat and also about the treatment methods. And I hope, and I'm sure you have spent a lot of time to prepare the slides with the live videos and all. So thank you very much again for your very informative presentation, Dr. Vipuli. And next, I would like to thank Dr. Dayani Sirivardhana, our moderator today. I know Dr. Dayani is a very busy clinician. Even though she is very busy, she accepted our invitation to be the moderator today. Thank you very much, Dr. Dayani, for being here with us as the moderator. And next, I would like to thank Dr. Susantha Malavarachi, President, Sri Lanka Veterinary Association, and all the executive committee members of the Sri Lanka Veterinary Association for their continuous support given to conduct this webinar series. And next, I like to thank all the participants who have joined from Sri Lanka and also from other countries, especially the participants who have joined from South Asian countries. Thank you very much for joining with us today and also for your very active participation. And I would like to mention that this webinar is available for you to watch later in our YouTube channel. So those who have missed the webinar today, they can watch the webinar later by logging into our YouTube channel, SLVA YouTube channel or SLVA web page, or this is also available in Sri Lanka Veterinary Association Facebook page. So please convey this message to your friends because they can later watch our webinar series using the internet. And next, I also want to mention that our next webinar that will be on next Friday, Sunday, that is 26th June, Sunday at 1:00 p.m. Sri Lanka time. And the topic is treatment modalities and medications used in ornamental fish diseases. And the speaker is Dr. Samantika Jaguda. So I invite all of you to join our next webinar that is on next Sunday. So again, I thank Dr. Vipuli, Dr. Dayani, and all the participants for joining with us today and hope to see you all on Sunday. Thank you.
Thank you.
Thank you, Dr. Vipuli. Thank you.
You're welcome. My pleasure.
Apsara, shall we end the session then?